Let's talk a bit more about POCUS in urgent care. Hello and welcome to this week's Urgent Bite, brought to you by the Royal New Zealand College of Urgent Care. My name is Guy Melrose and today we're returning to the topic of point-of-care ultrasound and its use in the urgent care setting. Dr. Barbara Blok has dual fellowships in both emergency medicine and urgent care. When she's not working in the emergency department of Auckland City Hospital, she can be found working at the ScoreSquad Urgent Care Clinic. At last year's Urgent Care Boot Camp, she talked about a 2-week trial of POCUS in urgent care that she had undertaken, and she shared with us the results and her experiences.
I'm Barbara. I'm an emergency medicine specialist. I work at Auckland City Hospital, but I also work in urgent care. And in ED, you may or may not know, we're expected to see at least one patient an hour. In urgent care, 3 to 4 patients an hour. And so I was wondering how I would fit in ultrasound into urgent care practice, because where I work at Shore Care, it's pretty busy and, we see a lot of patients. So I don't have any conflicts of interest, but I would like to say thank you to Deb Stanley, who's at the back of the room. She works for Sonosite and she lent me an M-Turbo machine for a couple of weeks, and she also gave me two of the slides for this talk. So I used a M-Turbo Sonosite for a couple of weeks as a trial. I made sure that I had verbal consent from the patients. And basically the way I see ultrasound, I see it more of an extension of your physical examination rather than a diagnostic tool, because I'm not a sonographer, I'm a doctor. And in general, I think ultrasound's more helpful if you have a positive finding. And I also think it's good to keep in your mind what you would do with the patient if you weren't going to scan them, and only let a positive finding change your mind. I have a few rules that I try to keep to. I sometimes break them, but basically keep it simple. Make sure it's a yes-no question. So for urgent care, is it an abscess or is it cellulitis? Only a couple of weeks ago I went to drain an abscess and I didn't scan it first, and there was virtually no pus, and I wish I had, but yeah. Bread and butter for ED, obviously AAA scanning and fast scanning. Is there a fracture? Is there a pneumothorax? Those are all good yes-no questions. Be a little bit careful with gallstones. I don't know about you guys that scan in the room, but if I'm not looking for the gallbladder, I find it, and if I'm trying to look for the gallbladder, I never find it. So try to not pick up the probe unless you've got a clear question. Just fishing or having a look is usually not a good idea. So who did I scan in basically over 10 shifts I saw 205 patients, and I did 17 ultrasounds. So that's roughly 8% of the patients that I saw. The shift duration varied between 6 and 8 hours. And on some shifts I didn't scan anyone, and on other shifts I scanned up to 4 patients. I wasn't actually measuring efficiency, but I didn't see that it slowed me down a lot because I had the machine plugged in, ready to go at the bedside. So what did I scan? The most common was DVT, and that kind of surprised me because I don't actually like scanning for DVT, and sometimes I find it quite technically difficult. But if you actually think about it, in urgent care, we do see a lot of people with unilateral swollen legs, and I don't know why, but they always tend to present on Friday evening or the weekend when you can't get an ultrasound. So my question is there an above-knee DVT? As I say, I'm not a sonographer. I'm looking from femoral to popliteal. 3 renal patients, is there hydronephrosis? Yes, no. Early pregnancy, it's fraught with a few problems, and I always very carefully explain that it might be too early to see anything. I'm ED trained, as I say, so I had an elderly patient walk in with back pain, and so I have to rule out a AAA. But also, what's quite useful is a post-void residual volume, which is a lot better to rule out cauda equina than physical examination or a rectal examination. Rib injury, I'm still learning that really, but pneumothorax is better on ultrasound than plain film, as some of you will know. I had two abdominal pain patients. This is where I kind of stepped outside of my rules a bit. And one was for free fluid with an ovarian cyst. The other one thought she might be pregnant, so I thought she might be an ectopic, but the pregnancy test was negative. So when I'm scanning for DVT, I do a pre-test probability and a Wells score, and all of the 7 patients were negative for above-knee DVT. Most patients still require a formal scan, so it's important to have in your head what the Wells score is and what you would do. So is it a low probability and you're going to rule out with a D-dimer, or are you going to need to get a formal scan? So I followed the same pathway, and the little box up there shows you the Auckland Regional Health pathway. So if you've got a Wells score of more than or equal to 2, then you arrange an ultrasound. Interestingly, they say if there's going to be a delay of more than 6 hours, you should consider Clinician. I don't think I've ever got a formal scan in less than 6 hours, but my scan actually helped clinically with 2 patients. So what I did was I withheld the Clinician, essentially, and that was useful for 2 patients. One was post-knee replacement, and the other one was she had quite heavy dysfunctional uterine bleeding, and I didn't really want to give her Clinician. And both of those patients had formal ultrasounds, which were negative. And also, I think point-of-care ultrasound for DVT can be useful if there's a proximal DVT, so that you can refer them to hospital. This is a slide from Deb, thank you. This is showing the linear probes and just reminding us about the anatomy. There is a little bit of research out there about 2-point compression techniques, so that's just doing femoral and popliteal. In general, I wouldn't recommend that. That's not how I was taught. I basically go from femoral down as far as I can, compressing, and then go from popliteal up through the adductor canal. And as I say, most cases still need what you were going to do anyway, which is a D-dimer or a formal scan. This is something I was taught in the Postgrad certificate by Wendy and Jill, just to check for phasic flow in the femoral vein using colour Doppler. And that just basically shows that there's phasic flow with respiration, and it excludes approximately occluding DVT in the iliac vessels. 2 patients had alternate diagnoses. So one had cellulitis. That's the one on the left with what's described in the textbooks as cobblestoning, and then another patient had quite prominent thrombophlebitis. The hydronephrosis patients, 3 scans, 2 were negative. This one here is a 71-year-old lady who came in with flank pain, and she wasn't really behaving like a normal renal colic. She wasn't rolling around in agony. And she said, oh yeah, it's a bit sore, and she had some blood in her urine. And so I scanned her kidneys, and I mean, that might be normal on the left, but when you fan through the kidney, it clearly communicated with the renal pelvis, and she had what I thought was hydronephrosis. I can't show you the video because I couldn't get her name off the video, sorry. So I referred her to hospital, and she had a CTU which showed a 3mm VUJ stone and mild to moderate hydronephrosis. This is just an example of severe hydronephrosis. So this is a 15-year-old boy that I saw a couple of months ago now in ED, and he had had 4 months of back pain and been managed under orthopaedics for his back pain, and his back pain was not caused by a musculoskeletal cause, and he ended up having a proximal PUJ obstruction. Early pregnancy, I'm a little bit cautious with this, and I always careful consent with the patient and also explain that it might be too early and it doesn't mean anything if I can't see anything. Always use the obstetric setting, always use M mode for your fetal heart. An adequate image must have the uterus, a moderately filled bladder and the vaginal stripe all in one film. This lady here, I have to speed up now. We have to skip that. This is the lady with the back pain, reassuring normal aorta and normal post-void residual volume. This is the one, rib fracture but no pneumothorax. I think ultrasound's useful for selected patients and it can change what you do. Most cases will still need formal imaging. It does require careful explanation to the patient, and I think there's a bit of work to be done around credentialing, training, and how you're going to store your images and ongoing audit. And keep to your scope of practice, but first of all, work out what that is. In your handouts, there's some resources on ultrasound. Calvin Ward's leading urgent care ultrasound in New Zealand. There's also a lot of training courses you can do. And just a plug for Wendy and Jill at UIE, they're running their ultrasound course in Rarotonga next year, and I went last year and it's fantastic. So just plug for that. Thank you.
My thanks to Barbara for allowing us to use this audio as a podcast. Attached in the show notes are some websites and resources she recommends you check out, some of them mentioned in her talk. POCUS has the potential to improve urgent care practice, and clinicians like Barbara and Kelvin Ward are leading the way here in New Zealand by showing us the many benefits it can bring. There are a number of our community acquiring these skills, and a number I know that are keen and interested. We will continue to return to the topic of POCUS on this podcast, highlighting case histories of interest, discussing training and equipment, and sharing experiences. Please contact the podcast if you're an urgent care POCUS user and have any stories or experiences you want to share, and if any of you have any comments, questions, suggestions or corrections, email podcast@rnzcuc.org.nz. Now we'll be back again next week with another podcast. I look forward to seeing you all then, but for now, thanks for listening.